This poster as well works on deep learning models automated scoring of hand radiographs for rheumatoid arthritis. This work aims to develop automated methods for the vendor-hidden modification of the SHARP score for rheumatoid arthritis using whole hand radiographs as input. Here we consider two research questions. The first one is direct score prediction, which we refer to as regression, and the second one is SVDH-based RA severity classification, which we refer to as classification. Rheumatoid arthritis, or RA, causes symmetrical polyarthritis in hands, feet, and wrists, with bone erosion and joint space narrowing. It is diagnosed and monitored mainly using hand and foot X-ray. As most commonly adopted RA quantification criteria in clinical trials, the SVH scores consist of two scores for bone erosion and joint space narrowing. Despite its high sensitivity, its high complexity, the presence of inter-observer disagreements, and the expertise required limits its application for routine clinical use. In this project, we use a published dataset that consists of 3,818 double-hand X-ray images collected from diagnosed suspected RA patients. The average of the SVH scores reported by two experienced radiologists was provided. For the classification, we split the score range into 10 classes with smaller range at the lower end of the score range. The data published also assessed the differences between the scores given by two radiologists who achieved a Pearson's correlation of 0.97 but relatively high mean absolute error and root mean squared error, suggesting intrinsic ambiguity of the scores. In our projects, we first perform image preprocessing, including standardization and augmentation. We choose MobileNet V2, ResNet 34, and ResNet 50 as our backbone models. For the regression problem, mean squared error loss or the smooth loss was used. For the classification problem, cross-entropy loss was used. We then performed transfer learning to further improve the model performance using RSNA pediatric bone age challenge dataset. 3 different model fine-tuning schemes were attempted for our RA data. Eventually, we performed the ensemble learning to stack the best independent models and use GradCams to provide some explanation for the model prediction. Our results for SVH score prediction shows that transfer learning and ensemble learning could substantially improve our model performance. Our best model attained almost comparable accuracy as experienced radiologists. Its Pearson's correlation coefficients was about 4.5% lower, but it achieved almost as good mean absolute error and root mean squared error. However, we can see that the predictive error increased with the true scores, and several severe cases were underscores. This could be caused by the reduction in sample size when score increased. Our GradCam results shows that our models could successfully look at joints involved in SVH scoring, but however, as shown by the false negative and false positive, there were some structures that were overlooked by the scores, and some healthy joints could be confused with damaged joints. Also, the models could look at irrelevant anatomical structures such as the middle part of the bones. Our results for RA severity classification showed a rather inconsistent effect of transfer learning, probably due to our choice of using cross-entropy loss, which cannot account for the ordinal relationship between classes. Our best model is the ensemble model that achieved an accuracy of about 0.36, which is quite low. Looking at the confusion matrix, we can see that the majority of the misclassification was made between neighboring classes, and our models had relatively poor performance among early and moderate stage cases. This is probably again due to the intrinsic ambiguity of the class definition reflected by the high mean absolute error and root mean squared error between radiologists. Our GradCam result again showed that our models could focus at joints assessed by the SVH score, but again, however, can confuse healthy joints and damaged structures. In conclusion, our score prediction results show that the great potential of conventional deep learning models in automating the SVH scoring. Also, pre-training the RSNA datasets enabled large models such as ResNet to learn more features that later became useful for our tasks. Our works have a few limitations that should be addressed in future studies, which includes data imbalance and our issue with the loss function. Also, we should further improve our models to ensure that it pay more attention to or focus more on the structures of interest and to have higher accuracy in distinguishing between damaged and healthy structures.